هنبلش session in the afternoon session today. It will be the clinical symposium about diabetes and Ramadan in collaboration with DAR. The first talk will be the DAR IDF ADA guidelines. We are pleased to have online Dr. Mohamed Hassanein, the professor of medicine at Mohammed bin Rashid University in Dubai, senior consultant in endocrinology and diabetes in Dubai Hospital, professor of medicine, Gulf Medical University, and of course, everybody knows he is the founder of DAR. He will be talking to us about DAR IDF ADA guidelines.
Thank you very much for the kind introduction and the kind invitation. I'm sure that you've all been enjoying an excellent conference, and thank you for Dr. Wiam for the kind invite. I'm sorry I cannot be with you in person. So I've been asked to cover the diabetes management during Ramadan, a bit of an update and the balance between faith and science. I have no conflict of interest for this presentation. As I'm discussing the new guidelines, I have to make tribute to all the very good friends and colleagues from across 5 different continents who were part of this new update and indeed have been part of previous guidelines and research into the field of diabetes and Ramadan, which has made the issue for us a lot more evidence-based rather than what the case was in the past. Fasting Ramadan varies from country to country, not because of less religious attitudes. However, in some countries, being on insulin directly makes the person, the healthcare professionals, and maybe the religious authorities agree on not to fast. In our region, it varies also. We see in Saudi Arabia and perhaps slightly less in other Gulf countries. The guidelines have evolved during the last number of years. If I were to reflect on the guidelines of 10 years ago, we would see from them that there is very little number of people who would be fasting. Basically, if you can look here, you will find it's only people with type 2 diabetes who are well controlled and maximum being on basal insulin. Obviously, as you saw from the previous graph, the reality is a bit different. So as we think of risk assessment for the Ramadan fasting, of course, it has to be individualized. And certainly, we have to individualize the care based on clinical practicalities as well as being religiously aligned. The last 25 years have seen a huge evolution in the field of diabetes and Ramadan. In the last 4 years, just the last 4 years, 272 publications on diabetes and Ramadan were published. And this obviously has reflected on our guidelines. A major development in the previous guideline, in the 2021, was the risk calculator. And since then, as you can see from these 2 slides, there has been numerous studies from across the globe, including a systematic review and meta-analysis that shows the validity and the usefulness of this simple tool of the Ramadan risk calculator, which anybody can use across the globe. Alhamdulillah, we have won the Sheikh Hamdan Health Innovation Award, myself and my dear colleague and friend, Dr. Bashar Effendi, and the very good friend, Dr. Munir Al-Arouj, as well as Dr. Shehla Sheikh from India. We reflect on all the new studies that have been published over the last number of years. Specifically, over the last year, we as DAR, we have published over 13 different studies that has really shaped the new development. The development took a process of reviewing the evidence, reviewing the new studies, and having a consensus which was circulated with all the 59 authors so that we can ensure that all the feedback is accumulated, looked at, and addressed. So eventually, I'm proud to say that this last risk calculator has the consensus of all the authors for it. Indeed, I'm delighted to let you know, all dear friends, that it is part of Chapter 5 of the Standards of Care of the ADA of 2026, and you can certainly find it on the Diabetes and Ramadan Academy application, where wherever you are, you can advise your person with diabetes if you have the information about their health. So let's go through some of the points. Pregnancy, we completely say it's out, it's high risk. Any person with hyperglycemia in pregnancy, simply we do not know about the safety for the fetus or for the mother, and consequently, in the absence of the safety data, as well as the fact that is only being a temporary measure, then there is no need for the mother to take that risk. Type 1 diabetes score more than type 2, and duration of diabetes is an important factor to take into account as well. All the medication that we have available have been regraded based on the latest evidence. Of course, we nowadays have plenty of new studies and plenty of new formulations of molecules. Some of them are with less concerns during Ramadan fasting, and consequently the scoring. Now, all of this are highlighted here in green because you can change from one type to another to try to minimize the risk of fasting for the individual. Hypoglycemia, awareness, severity, and frequency is also a very important point. And indeed, this point is also modifiable, which is really quite important to take into account. The level of hyperglycemia, of course, is a very important factor. And when you think of the HbA1c of the individual, as well as the frequency of blood glucose monitoring, these are also modifiable factors, and the latest evidence, which I will share with you shortly, have guided us that indeed this is very important. CGM, as you can see here, scores minus 0.5 because of the ability of the CGM to predict and prevent the problems. Acute diabetes emergencies are also an important factor to think of, and consequently they score. Cardiac or vascular problems in general, the score for them has not changed. If it's unstable, it's out, 6.5, it's high. If it's stable, then it takes a score of 2. A very important new development in the calculator is the presence now of microvascular complications. Nephropathy has been there before, and the grading is based on the eGFR. But what we have from the latest information, that the presence of 1 versus 2 versus 3 microvascular complications make a big difference in the ability of fasting. Definitely the cognitive and frailty function of the person, as well as their age, is an important factor, specifically if the person is above the age of 70 and with no support. This is modifiable by virtue of the fact that I maybe can stay with a relative or a friend to help me in case I have any problems. Finally, the last 3 points are related to the physical ability, job of the person, the hours of the fasting, and whether the person received fasting education or not, which should be the standard of care nowadays. If the person scores more than 3, that is 0 to 3, that's low risk, and hence the person can fast safely. If the person scores between 3.25 and 3.6, then this is uncertain, and they have here the option of fasting or not. If the person scores more than 6, then certainly this is high risk. And let's remember, we are talking about risk, we are not talking about certainty. And that applies to any risk of smoking, risk of anything else. It's not necessarily it will happen. So with all this in mind, it's time to reflect. The question really here is not just quantifying for the risk. The question that most patients want is they want to fast. Many of them want to fast. Of course, not all of them, but the majority want to fast. And the question for us is, how can we address and minimize the risks? Technology plays a big part. I'm communicating with you now via technology. Technology can help with the risk assessment, with the education, with public awareness, and certainly with glucose monitoring as well as insulin delivery. This is a screenshot from my hospital. The electronic medical records of our hospital has the risk of the part of the screening, the Ramadan risk score, where you would screen and then it would come to you with the exact risk level. Indeed, as I mentioned, you can find it in the ADA Standards of Care or the IDF website. But to me, what's very important is thinking of this important algorithm. If you want to take one picture from this lecture, take this one. This is really the roadmap for what should we do once we see a person. So it's not good enough just to say to me, Mohamed, your risk is high or moderate or even low. The question is, how can you help me to modify that risk level and to have safe fasting during the month of Ramadan, or safe Ramadan if the person is not fasting? Low risk does not mean no risk. So still, people with low risk would need to have the education and the full plan, the individualized plan. But I would first like to focus on the person who decides not to fast. Frequently, they are ignored, but that person would probably not be able to eat and drink in public, and also probably is going to feast with the rest of the family during iftar time. So they are also exposed to the hypo and hyperglycemia that the rest of people with diabetes who are fasting are also exposed. So we really need to think of this person. And when we looked into this paper, looking into people who did not fast, the vast majority of them are people with long duration of diabetes, older in age, with multiple complications, and possibly treated with insulin as well. Not all of them, of course, but the vast majority of them. Let's now think of the person who decides to fast. Certainly, they need the education as much as the other person as well. And then we need to address the modifiable risk factors. It is also would be very helpful to have a trial fast. The month of Sha'ban or the month of Rajab, depends on when you have assessed your patient, could be a good opportunity for 3 consecutive days of fasting. Following that, a personalized management plan would be according to the outcome of all of this, and then the person would be able to fast. Education is key, and I'm sure that during the course of the conference, you will be discussing this important topic very well. I'm delighted that the Dar Safa app, not the Dar Academy, but the Dar Safa, which is dedicated for people with diabetes, and the education come in multiple languages, because we really need to address people with diabetes for education. We frequently do the healthcare professionals, but we forget the people of diabetes, and we frequently also forget to engage with the religious community as well as the media and the social media active persons who have strong influence, and it's very important that they get the right messages. Unfortunately, from the Dar Global Survey, which was held over 2 years, we only saw 60% receiving education. So 40% did not. And indeed, the vast majority of the education was delivered by the doctor in clinic during their routine clinical practice of a duration of less than 15 minutes. So clearly, we need to improve on education. When we looked into education for people with type 2 diabetes in this study, who were either on basal bolus or on pre-mixed twice daily insulin injections, more than 40% did not receive education. And SMBG, which we frequently confirm that they need to be done more frequently in Ramadan, was only done more frequently in less than 14%. So certainly there is a gap. So this point took me to the frequency of monitoring. We do not say every person needs to check 7 times a day, not at all. The frequency would depend on the type of medication as well as the other factors that we've mentioned before, the level of risk of the person, the type of job, the nature of the fasting. All of these issues will be important factors, and this is the minimum frequency for the different types of therapy that we have for our patients. But the good news is even simple education, similar to what I've showed you in the Dark Global Survey, did have a serious impact because it managed to reduce the risk of hypoglycemia by nearly 50%. Then come the point of hyperglycemia. And unfortunately, we do not apply the hadith an Rasul sallallahu alayhi wasallam, where the hadith recommends a third of the stomach is for food, a third is for drink, and a third to breathe. Unfortunately, in Ramadan, we see serious hyperglycemia, and the data here shows that hyperglycemia was even higher than hypoglycemia. So certainly, we need to think of this because it's quite important. And if we feel that hyperglycemia before Ramadan is going to protect the person against hypo, well, let me share with you the data from this last study that we've published. People with an HbA1c above 9 had over 8-folds the severity or the frequency of hyperglycemia during the month of Ramadan compared to a person with an HbA1c of less than 7.5. In fact, 10-folds or even close to 11-folds higher odds of severe hypoglycemia requiring emergency care in people with high HbA1c. Well, you might say that is predictable. They are already before Ramadan poorly controlled, but maybe they will not hypoglycemia. Well, unfortunately, this is not true because in the same study, we can see that daytime hypoglycemia is over double in those with an HbA1c above 9. It is more felt by them, so they break the fast more, triple the frequency, and needing to go to emergency was also higher in those with a higher HbA1c. So moving on to the issue of the trial fast. Ideally, it needs to be on 3 consecutive days, and that obviously can give us a good feedback on how did it go. Did the dose adjustments or choice of treatment or the timing of therapy, did the education and the more frequent monitoring, as well as the dietary measures that were applied, did they help the person to say, yes, they can safely fast or not? That is really quite important. Lastly, post-Ramadan. Post-Ramadan is very important. We have to review the glycemic control. We have to assess the frequency and severity of any adverse problems during the month of Ramadan. And of course, this will help us in future fasting feasibility, as well as modify the issues that need to be modified for the following days, weeks, and months. So, ladies and gentlemen, in conclusion, fasting could be challenging, not just for people with type 2 diabetes, but for us as well as healthcare professionals. We definitely need a systematic approach for risk calculation, which is really quite essential. Modification of the risk factors that could be modified for better safety during the month of Ramadan is really key. And that could be done with a number of aspects, including, certainly on the top of it, patient education. Fasting should not be an excuse for inertia. We frequently see people with poor control, and we do not intensify treatment because of Ramadan. Ramadan should not be an excuse for better fasting outcome and better Ramadan safety for everyone, whether they fast or not. Thank you, and I hope you enjoy the conference.